So another concept or goal for a splint is to decrease joint strain. With an NTI device, you can increase it if you goof it up. It all has to do with the vertical dimension of occluding. We want to minimize the vertical dimension of occluding to minimize the rotation during the event so your condyle is not hung out to dry in these excursive, protrusive events. So if this discluding element, and these are the images from the original NTI device, and it was usually the upper with that big, goofy-looking discluding element. If you were to make this thing, if this was much taller, in an excursive movement, you are forcing a further distraction of the condyle. You could really make someone much more sore that way. So if this patient here said, my jaw is kind of sore now, you put the device and you have them go to the side and squeeze, nothing's touching, and they kind of go, oh yeah. And so you shave down the discluding element, you close the vertical dimension as much as you can so there's daylight between these potential contacts. That same person at that same visit will go, they'll squeeze with the device and it won't hurt them. I want daylight disclusion in all excursions or protrusions. Daylight disclusion. And I think about those speaker wires. It doesn't matter how close you get those things, you get no sound out of your speaker until they touch. If the molars are not touching, you're not getting innervation to the elevator. So you're getting minimal elevation contraction intensity. Some people will protrude with their NTI device, and it's real easy to goof up and have the back end of this discluding element too tall. Because when you put it in, it's parallel with the mandibular plane when they protrude. You get rotation and protrude and translation. The back end elevates as they protrude. We'll show later in the chair side sequences on how you have to shave that thing down. We'll talk about anterior open bite a little bit more in detail. Sometimes you can take the whole posterior maxillary arcade and intrude it with these new temporary anchoring devices in orthodontics. Here's this little screw here. This is just the craziest thing. With a topical anesthetic, they actually screw it into the buccal wall, buccal plate. The patient doesn't feel it. It's like what I felt. I felt pressure. It didn't hurt. I felt pressure. I was expecting others. I'm glad I know what it feels like now. They put the screw in there. And now this anchored screw can intrude or elevate these molars. So there's a screw right there, or where is it? It's up here, and there's this elastic that goes like this, and this whole thing will be elevated. I have a couple of patients doing this right now, and I'm taking photographs as we go. In about 8 months, I'll have one of my little, one of those little things.
This is how they open after wearing them?
No, this is just this right here is current orthodontic practice to intrude or elevate molars they put these anchoring screws all over the place now. You want one tooth over here, it just pulls it that way. It's a really handy application to an orthodontist. It's like, yeah, so what? It's easy to do. I would take a patient, if this was a migraine sufferer who now felt fabulous, who would not like to order spaghetti like this anymore, I can now go to the orthodontist and he'll say, oh yeah, sure, I'll just intrude those things with the screws. It's easy. 5 years ago, they go, I don't know what you're going to do. Yeah. So we're having these little implant screws here on one side, and there's this little thing that goes across, and it's going to elevate just those two teeth. It's going to allow me to shave this thing down. So now let's see if we've learned the code. In non-working side interferences causes muscle hyperactivity. It's right out of a textbook. There is the non-working side interference causing muscle hyperactivity, and that's the image that the textbooks will show. Let's call that an interference. Let's not call it that, because we've already closed. It's too late. We're trying to reopen now. On the non-working side, because this condyle is translated, we thought the food should be over here. So on this non-working side, the translated side, that's not really an interference, it's a resistance contact. Is it causing the muscles to be hyperactive, or is it allowing for this intensity? You can't stop that part. That hyperactivity refers to that temporalis. You can't stop that from happening. You have to stipulate that because that's dentistry. So during occluding, dentistry, the translating side contact allows for excessive muscle intensity. So now we are looking at the pathology for what it is. So here's how an incisal edge resistant contacts allow for minimal intensity.